Hi, my name is Mujjahid Abbas, and I'm talking about how does the RAP lie for reimbursement, financial considerations for endoscopic anti-reflux procedures. I thank SAGES and the organizers for this opportunity. I don't have any financial disclosures. You will hear, and we have been hearing about all these multiple endoscopic interventions for anti-reflux purpose for almost 2 decades now. If we look at the regulatory process status and approvals, I will talk about Sofix first. In 2007, it was approved by FDA for full thickness application. 2016, Sofix Z device was approved with new series of use fasteners for ligation in the gastrointestinal tract, narrowing of the GE junction, reduction of hiatal hernia, and treatment of symptomatic chronic GERD. In 2007, the Sofix HD and third generation Sofix Z devices were approved for above indications as well as in symptomatic patients who respond to pharmacological therapy and patients with hiatal hernias larger than 2 centimeters with a laparoscopic hiatal hernia repair, reducing the hiatal hernia size to 2 centimeters or less. The evolution of endoluminal fundoplication Sofix device started with the below the Z-line plication that was only gastrogastric. There was no wrap. TIF1 went up to 1 centimeter above the Z-line. Again, it was still no wrap. In TIF2 modification brought the plication 1 to 3 centimeter above the Z-line with true wrap performed. Medigus SRS endoscopic stapling system, or Muse Medigus, was cleared in 2012 initially, and then with modifications in 2014 for management of GERD. Strata was initially approved in 2000 under CSM and for treatment of GERD. And currently, as we know, Medairi Therapeutics owns Strata. Tirosafir is a bulking agent approved for treatment of urinary and fecal incontinence, submucosal injection. However, it is investigational for management of GERD, at least at present. To get these devices approved, societies have worked for a while. American Society of General Surgeons gave its statement in 2011 supporting the treatment of use of endoscopic treatment for GERD management. And similarly, ASGE in 2015 supported the use of Sofix and Strata, although they found some discrepancies between the subjective and objective outcome measures. However, they concluded that these techniques represented potentially new therapeutic indications for GI endoscopy. And they recommended prospective trials using objective measures of GERD as the primary endpoint. SAGES gave a strong recommendation based on the moderate quality evidence that TIF using Sofix could be performed with an acceptable safety risk. And Sofix resulted in better control of GERD symptoms than proton pump inhibitor treatment in the short term. In the long term, effectiveness was noted to decrease, and SAGES found no comparative control trials between TIF and surgical fundoplication, but preliminary evidence suggested that surgical fundoplication can be used safely after TIF failure. Based on recommendations of the societies like that, you would assume that there would be a strong acceptance from insurance providers. However, if you go on websites of large insurance companies, even, for example, this update in 2020 on a Primera website says TIF as an investigational procedure for reflux. And Strata similarly has been declared investigational as a treatment of GERD. and similarly endoscopic submucosal implantation of prosthesis or injection of a bulking agent, all are considered investigational treatment of GERD. Medicare HMO and PPO, however, approve implantation of these devices. However, patient must be suffering from severe or life-threatening gastroesophageal reflux disease, and condition has been resistant to medical management, and in addition, patient has either esophageal involvement with progressive systemic sclerosis, or has foreshortening of the esophagus, such as there is insufficient tissue to permit a valve or reconstruction, poor surgical risk for valvuloplasty, and patients who have failed previous attempts at surgical treatment with valvuloplasty procedures. In 2016, physicians and hospitals were allowed to use CPT code 43210, EGD with esophagogastric fundoplasty and APC 5331 complex GI procedure, especially for TIF. And physician CPT code 43210 with EGD FID and flexible fundoplasty. Other codes, ICD-10 codes, which are usually needed or used for communication with the insurance companies, like K21.0, GERD with esophagitis, 21.9, GERD without esophagitis, R12 for heartburn, etc. Some of the common CPT codes, 43201 is used for EGD with submucosal injection, 43210 we talked about, TIF, 43236 for injection of submucosal substance, 43499 is an unlisted procedure for esophagus, and 43999 unlisted procedure for stomach. You will use many times laparoscopic codes like 43280 for hiatal hernia repair and 43821 for laparoscopic paraesophageal hiatal hernia repair. DRG codes for hospital reimbursement, DRG 326 to 328, and revenue code 0278 for implants. Financial considerations, it's a good idea to always check with the insurance pre-authorization. I'm sure everybody does that. Many times you will need to use third-party authorization, and in the end, self-pay is an option as well. Physician payment for CPT 43210, EGD with endoscopic fundoplication, has been given 12.43 RVUs, and using the conversion CMS CY 2016 conversion factor, the unadjusted payment amount of $445 for EGD with endoscopic fundoplication. For hospital outpatient, CPT 43210 has been grouped into APC 5331, complex GI procedures, and has a national unadjusted payment amount of $3,613. As mentioned before, TIF 2.0 procedure is covered benefit for all Medicare beneficiaries across the country, to keep in mind. You should know the indications when you're talking to the providers from the insurance companies: symptomatic chronic GERD, response to PPI, and hiatal hernia to less centimeters, TIF device, helical retractor, tissue mold, invaginator, and Serosa fused fasteners. I'm sure somebody will talk about the device in detail. It's good to know some of the data to convince the payers that the device, compared to medical management, 75% people were reported to be completely off PPI, 82% esophagitis improvement or resolution, according to the study quoted by the device manufacturers. And similarly, cost difference and cost savings with endoscopic anti-reflux procedures compared to loss of work and other medical management for prescription cost, etc. TIF has a good patient access program used they use a third party on behalf of the patient. In phase 1, you request for a pre-authorization or predetermination. Patient is informed about the decision from the insurer about approval or rejection. In phase 2, if the procedure was denied, an internal appeal can be done on behalf of the patient, where a peer-to-peer discussion can be requested. And if it is approved, fine. And in another case, if it is not approved, then the phase 3 is an external appeal process where an external reviewer discusses it with the insurer and is conducted by an independent review organization. With this, I'll conclude my talk, and I will thank everybody for their time.